Good evening. My name is Brother Victor J. Narcisse III. I'm an internal medicine and geriatric physician in Houston, Texas. I practice at the Houston Methodist Hospital, board certified in internal medicine and geriatric medicine. And we're here today with the Surgeon General's initiative to talk about something that's near to dear to myself and to so many in my community. Prostate cancer is something that affects my family, has probably affected your family, my chapter, your chapter. Our community is our concern because African-American men seem to get cancer of the prostate and die from it at a higher rate than others. Complicated reasons for that. They're not fully understood, but we'll be talking and exploring that a little bit more today. We'll speak about the factors that are affect risk, things that you can do to get evaluated for prostate cancer, things that you might do if you've been diagnosed with prostate cancer. So tonight, to discuss this, we have a survivor, a hero in Brother Marvin Evans. Brother Evans is a director of project management office, and he works with the Health and Social Services business domain, supporting the Tennessee Department of Health. He's had a career in business development, sales, support, manufacturing. Brother Evans, I want to thank you so much for being here tonight.
I think it's good to be here.
Additionally, we also have Brother Kelvin Moses, MD, PhD, FACS. He probably has more titles than that, but we just don't have enough time to cover all those things. He's an associate professor of urology at Vanderbilt University Medical Center. He trained at Baylor College of Medicine. He was a medical student that I knew when he was in training. He went on to do surgery residency, a urology residency at Emory University, and then a fellowship at Sloan Kettering in New York. Prestigious organization. And his clinical interests are in advanced prostate cancer, advanced kidney cancer, testicle cancer, penile cancer, adrenal cancer. And he works as the director of comprehensive prostate cancer clinic and has research interest in health literacy, cancer outcomes, advanced prostate cancer, clinical trials, and disparities. And as a result, I can think of none better to discuss prostate cancer than Brother Moses.
Thank you, Dr. Narcisse, Brother Victor, and Brother Evans. Good to see you both.
Good to see you.
The pleasure is ours. Brother Moses, could you help us understand why prostate cancer is such a big issue in African-American men?
Yeah, and that's a good place to start. We know a lot about cancers like breast cancer. There's such great advertising and advocacy, and even for colorectal cancer, there's commercials, a little pill jumping around on the screen. But prostate cancer still tends to be one of these less discussed ones. It's important in Black men, number one, as you mentioned at the outset, Black men in the U.S. have the highest incidence of any group of men in the world. And that includes our brothers in the Caribbean and West Africa. We also die at more than twice the rate from prostate cancer compared to white men in the U.S. And that's been pretty consistent over the last several decades, at least since data has been known about it since the mid-70s. And because of these differences, it's imperative that we educate Black men about prostate cancer, that Black men educate themselves about prostate cancer, and spread this information to their family members, their friends, their colleagues, because part of the issue with incidence and dying from prostate cancer is that sometimes we're not aware of what it takes to find out about it, but sometimes we're also not aware of the treatments that are available as well. So I think this is a good outset to define why we're here and frame the conversation.
Well, I agree that education is really one of the keys to this concern, but it's still so difficult to understand why there seems to be such a disparity.
Yeah. The incidence, the higher incidence is not really well known. As I said, we have the highest incidence compared to even our ethnic cousins, I guess you would say, in the Caribbean and West Africa. So there probably is a genetic component to it. There's probably a dietary component to it. There's probably an environmental aspect to it. Prostate cancer, like a lot of cancers, are a disease of inflammation, and there may be a level of stress that's associated with incidence of cancer. The fact that it presents at worse grade or higher grade, more aggressive, and at younger ages compared to, say, white men in the country, again points to some exposures that we experience that are not seen in others. And so there clearly is going to be some sort of relation to changes that are in the body in relation to stress, in relation to a racist society. I mean, some of the things that we see in prostate cancer are mirrored among women in breast cancer, and in all of us in colorectal cancer. And so that has to be a contributing factor. Now, in general, family history does increase the risk of diagnosis of prostate cancer and diagnosis at an early age. And so it is important to know your family history. If brothers, dad, uncles, grandfather had prostate cancer. I know growing up as a young person, it was always said, don't be minding grown folks' business. And sometimes we didn't talk about things that were going on in our family because of that. And there was a reason for that. But I think we need to grow a little bit beyond that and say, okay, well, granddad, they said he had bone cancer, but bone cancer is actually really rare, and prostate cancer spreads to bone very easily. So, maybe that was it. And so knowing that information, those risk factors could be helpful in understanding why the incidence may be higher.
This is the time of year when there's a lot of conversation around prostate cancer. But because of exactly what you said, Dr. Moses, I would really encourage folks over the next several months, as you start to gather for the holidays, to spend some time with your family and have a frank conversation about your family medical history. I think that that's something that people don't usually do. We think of the holidays and family gatherings as a time to have conversations about the good in life and really not talk about the things that might be less exciting, less pleasing. But I really encourage the learning and the knowledge around the family history. And that would help inform what we call in internal medicine shared decision making, so that individuals can decide exactly how do you want to proceed with your healthcare. Because to make a good decision, you have to have knowledge. So part of the knowledge is here. Some of the knowledge is talking to your families. Some of it is reaching out to a professional, such as Brother Dr. Moses. And I'd love to hear more about your thoughts about how we should go about getting evaluated and screened to find the cancer perhaps early.
Yeah. So I'm going to follow up on what you just said and then answer your question. So just to sort of paint a picture about the family history, it's so important. We want to know if someone does have a family history of prostate cancer, but as we've discovered over the last few years, there's a gene that's related to breast and ovarian cancer that confers increased risk of prostate cancer and more aggressive. So that's really where it is important that we know everybody's family history. And you don't have to get into the weeds of everybody's health, but just to know those basics and understand what they've been through really feeds into, as Dr. Narcisse said, about shared decision making. Now, when we're talking about how do we get information about prostate cancer, for the most part, men get their first exposure about prostate cancer through their primary care physician. And because the primary care physician knows the guidelines about screening for cancers and heart disease and cholesterol and things like that. And so discuss with your physician, and I'll get into the guidelines later, but the screening test tools that we use for prostate cancer include a blood test called PSA, prostate specific antigen, and the rectal exam, or DRE, digital rectal exam. And though that information together gives us an idea of, is there an increased risk of prostate cancer? Do we need to do more testing? Or is somebody, relatively safe and we can continue to watch them? So those are the first two steps.
Excellent. There seems to be a great deal of discussion in the lay media about changes to the guidelines of who should get screened, when they should get screened, how they should get screened. And I'm afraid whenever things change in healthcare and that gets discussed in the media, people get confused. And then when there's a choice of the old or the new, people then decide which one do I like better. And if the new is better, but I didn't like it, they go with the old. And if the new and if the old was something that might be more advantageous, they just stick with the new.
Yeah. And I sympathize with my primary care colleagues because they have so many things they need to follow. But prostate cancer screening has guidelines from about 4 or 5 different bodies that make screening recommendations. Probably the main one that internists use is the United States Preventive Services Task Force. And about 10 years ago, they downgraded prostate cancer screening to no screening for anybody above 75. And then 2 years later, no screening for anybody. And it caused a lot of consternation because the American Urological Association, the American Cancer Society, the National Comprehensive Cancer Network, these other bodies were still making recommendations for screening. And so it did cause confusion. It caused confusion among physicians, and then it certainly caused confusion among patients.
What would you recommend?
So in full disclosure, I am the chair of the NCCN Guidelines for Early Detection of Prostate Cancer. But what I'll give is sort of a general guidance. It's not specific to the panel that I chair. In general, for Black men, I recommend, especially if there's a family history, to get that first PSA and DRE at age 40, just to establish a baseline. If that PSA number is very low, like less than 0.5, and the rectal exam is normal, then I would recommend getting checked again at 45. And then if it's still less than 0.5 and the rectal exam is normal, then start getting exams at least every year or every other year starting at age 50. And the reason I say that again is because Black men tend to be diagnosed at a younger age and more aggressive disease. So you don't want to miss that window of early detection. The reason for getting multiple ones is that a trend in the PSA is much more informative and helpful than one single value. Because I don't know if you had a prostate infection or you're an avid bike rider and you rode 100 miles the day before, or you had to have a catheter for some reason. All of those can drive up the PSA. But if I have a series of numbers, then I can be much more informative about, you are at higher risk compared to someone whose numbers have remained low or just go rising steadily over time.
The PSA is, again, very confusing for even some healthcare providers because of all the changes in the recommendations. But we often will pair the PSA with a physical exam of the prostate. And because of where the prostate lives, that causes some men fears about what that means about their manhood.
Mm-hmm.
Could you speak to that a little bit?
Yeah, definitely. Nobody likes the rectal exam. Okay. Like, I'm not going to be dishonest about that. I've had it done. I know Brothers Evans has had it done, probably Dr. Narcisse.
Yeah.
It's a part of the exam. One of the barriers is, women really start seeing physicians probably around 14, 15, 16, and usually on a pretty regular basis. And that includes pelvic exams early on. And so they understand that as part of the healthcare process. A lot of men, unfortunately, other than either the military exam or they play sports, they probably haven't seen a doctor in 3 or 4 decades by the time they, realize they need to at least get in and be seeing their primary care doc. And so that in and of itself is a barrier. I've had men tell me I'd rather die than have you stick your finger up my butt, and I'll tell them, well, you just might. There's information that can be gained from that, and men do have some trepidation. I tell them, look, I'm not here to entertain you, and when we walk out of this room, I'm going back to my wife, and you're going back to yours. Like there's nothing going on here. Okay, this is a clinical exam, and I can get some good information. I've diagnosed rectal cancers before, but certainly there's information to be gained. So I would say to brothers, take a deep breath, understand that you're doing this for your life and not for your entertainment. You'll be the same person when you leave, and do it for your health, do it for your family, do it for your loved ones.
Well said. Well said.
Mm-hmm.
I have had my prostate exam, my PSA done per the guidelines, and life goes on.
Mm-hmm.
We can keep going and doing things.
Mm-hmm.
But if we don't, you're right, you might make a choice that would adversely affect your life. Brother Evans, I'd love to hear more about your journey with prostate cancer. What made you go out to get checked?
Well, I actually started getting my PSC checked at an early age. I can remember I was living in Cincinnati at the time, and I had a sister for a primary care doctor, and I was turning 35. And she said, no, it's a little bit early. We're going to start checking your PSA now. And so I was getting mine checked at 35 on every year. And then as time went on, and I really don't know what the tipping point was, but I just decided that actually the primary care doctor I had at that time, I was just feeling that she wasn't, for that piece of my care, she wasn't as thorough as I wanted. So I just went out and found me a urologist. And so I would see her, then I go see him 6 months later. So I was getting either PSA or DRE every 6 months anyway. And so as the journey went on, fantastic primary care doctor, Ryan Meyer, and he's actually become the family doctor. My wife, my aunt, my cousins, I think he has about 10 of us. So he now has a family history of all of us.
My high school classmate.
Yeah. And
he's
so when I had,
I'll give he's not an
Dr.
alpha.
He was your classmate?
He made another choice, but I'll give him props. He's the current president of the American College of Physicians, which is the national organization of internal medicine physicians. So
that's right. I will let him know. Okay. And so I had, so I guess I've lost track now. I guess probably July of 2021, I guess. And I had my exam, and then he wrote me. He said, look, your PSA was normal. He said, but it made a big jump from the year before. So I said, I think we should just do a biopsy. It's probably nothing. And that's what I was telling you. I had that moment that I said I wasn't going to be. I said, well, can I just stop myself? I said, okay. So then, like I was telling Brother Moses and Brother Vic earlier, I called my friend Brother Abel, who's a doctor. I said, man, my PSA jumped, I think it was like 0.7 or something. He just said, you got cancer. You need to call Kelvin right now. That's what, can I call my urologist? He said, I don't care what you do. You need to call Kelvin right now. So while he was going in my ear, I was typing Kelvin the email. He said, okay, just make an appointment, come see me. And so we redid the biopsy. It came out the same. And so we got all my records sent over to him. And so one thing I really needed that Brother Moses did, he took the time and he did a cross section of the prostate, what it did and what it didn't do. And he showed me where they see cancer cells pop up, and more importantly, where they see cancer cells pop up in Black men. I don't remember the term for it, but I just remember he said it's the front door to the rest of the body. And we ended up finding a couple of cells up there, and that's really all I needed to hear. But he had my records, and so in project management, we do dashboards, green, yellow, red. And so he had put it in a dashboard. I see the dashboard. I'm like, that's a good dashboard from a project management standpoint. I think I had 4 red faces. He said, we have 4 red faces. That's 2 more than what I want. I said, oh, crap. So we went from that point on, and then we did the biopsy, and we did the biopsy right before Thanksgiving. And I remember he called me early in the morning on a Monday, and I was in a meeting. I saw his phone. I saw his number pop up, so I just took my headset off, took the call. And so he told me, I said, okay. So I went and told my wife what was going on. Then I got back from my meeting, and he said, enjoy the holidays. We'll talk about it. And he gave me a book, I think 101 Questions and Answers for Prostate Cancer. And so so God works in mysterious ways. So by the end of the day, I was just starting to think about it and the gravity of it. And one of my best friends, mentors, father figure died from COVID that day. And then that said, I don't have a problem. I really don't have a problem. And so once we understood my Gleason score, my cell type, I had every option available on the table. And I really owe that to getting tested early. Because I've had some people that have gone in there, they had to go straight to surgery. You didn't have a choice. And so being able to have a choice was probably one of the best things that happened. My wife grabbed the book one day and she was reading it while I was gone. I came home and she had sticky notes all in the book and highlighted passage in the book. And I don't do my books that way. My books are pristine. So I'm like, why did you do my book like this? And she said, shut up and read the book. That's okay. You read it. What would you do? And so she told me, she said, I do radiation. I said, well, I was thinking the same thing. And so that's kind of the course we went down at that point, because now we had a house united versus a house divided at that point. So at that point, I started researching the different types of radiations for prostate cancer, IMRT, SBRT, proton therapy. And I just drew a little chart down, pros and cons, yes, no. And then I remember Brother Kelvin telling me, he said, well, if you do radiation, he said, they can do it. You get the same amount of radiation, but you may get, if you do it 9 weeks, you get this much. 5 weeks, you get a little bit more. 5 days, you get that much. And so you're still getting the same amount. And so I don't know if I went past the question you asked, but I just got on the roll here. And so I ended up going with the 5 days. And he said, well, they'll put this little thing in called a spacer. I really didn't know what he meant until it happened. So that was probably, out of all the treatment, that was probably the worst couple of minutes, but it just lasted for a second. But my side effects were few. I mean, the worst one for me was I went through a period about probably 6 to 8 weeks where I was going to the bathroom about every hour. And I didn't realize my body was still healing at that point from the radiation. We ended up doing a cystoscopy. And so Brother Moses took me on a tour of my bladder. And then he wanted to make sure I was doing okay. And he told me that this is going to hurt you more than it hurts me. I said, say what? He said, just check and make sure you're listening. He said, if it's hurting, curl your toes. I said, I can't curl my toes any more than what they are right now. But he was able to show me where there was still just one little line of radiation burn. And so shortly after that, I really returned to a normal pattern of going to the bathroom. Question about sexual function. I'm 62. I mean, from that point on, I didn't see a tremendous difference. I just remember about probably the third day in, I woke up that morning. I just told myself, I'm going to be okay. I'm going to be okay. And so, and then, just up to that point, I started changing my diet. Even before I had prostate cancer, started working on changing my diet probably back in 2017. I'm not going to say it was full vegan, but it was just really paying attention to the amount of meat I was eating, the amount of fried stuff. So I just started reducing that. And so prior to even getting diagnosed, I dropped about 20 pounds. My blood pressure went down. And so that was all prior to getting diagnosed. And I'm really going to owe that to the fact that helped me post radiation. So, yeah.
Outstanding. Thank you for sharing some of the experiences that you had with your treatment. Brother Moses, could you speak to the types of treatment options that most individuals would have and what they could expect from those?
Yeah, definitely. And yeah, again, I appreciate Brother Evans giving that story because there's so much fear about what could happen. A lot of the treatments are based on your stage. And so that's kind of why we're talking about screening, because the earlier it's found, like Brother Evans said, the more options you have available. For most men, if they are diagnosed with very low grade cancer, or if they are low risk cancer, we actually can defer treatment and sometimes even avoid it because in a lot of men, they may have cancer, but it will never grow, it will never spread, it will never cause symptoms. And that's something called active surveillance. That is, it is active, so it is participatory. You get your PSAs every 6 months. We repeat biopsies, and then there's even other tests that we get like MRI or what are called biochemical tests. For men with localized disease, meaning it's contained within the prostate or maybe a small lymph node, you will typically get some version of surgery offered or radiation. Surgery you can do in an open fashion, meaning to make an incision at the lower part of the belly and remove the prostate, or you can do minimally invasive or robotic assisted, and you'll have little small incisions, and a surgeon is sitting at a console and kind of controls the arms and remove it. Has a little bit quicker recovery, maybe a little bit less blood loss. The types of radiation, Brother Evans mentioned those. You can do radiation seeds that are implanted directly into the prostate, or external radiation, and there's different versions of that. You can get what is called cryotherapy, which is freezing the prostate. There is something called HIFU, which is a type of ultrasound where they use ultrasound waves. And that's usually for men with very small lesions on one side of the prostate. And you can target that area and really trying to minimize side effects. But I wouldn't recommend that for anybody with higher risk disease. For men with intermediate or high risk disease, meaning their Gleason number is high or their PSA is above 10 or 20, you typically need more than one treatment. And so you can get surgery followed by radiation. You can get radiation with hormone therapy. Or in some cases, people will get surgery and chemotherapy for really aggressive cancers. The more treatments you get, the more side effects there are. So there are impacts on sexual function, on urinary control, on levels of pain. And so the more information that you can get about your particular stage of disease and your treatment options, then as Brother Evans said, you can make that decision within yourself, but with your family, you'll sort of understand, okay, there's going to be some bumps in the road. These are what they are. I'm ready for that. But yeah, there are lots of options available for treatment. But again, the earlier it's found, the better your recovery, the quicker your recovery, and get back to regular life.
Do you find that a lot of men are brought to the physician by their wives, by their families? They're the ones that are doing the encouraging?
Absolutely. Because prostate cancer in the early stages, you don't feel anything. Brother Evans, did you feel something?
Yeah. Not a thing. Mm-mm.
And sometimes it's hard to convince men to go see a doctor if they feel fine, right? I mean, Dr. Narcisse, you know that. Blood pressure, you can walk around with a blood pressure 150 over 100 and you can feel okay. But if you're coming in and you're having headaches and you lost vision in one eye, it's a little late. And same thing with prostate cancer. So a lot of times the spouses, the wives, the husbands, you know, and some men or the family members do bring you in because they do know, hey, you got to get your screening test done, or hey, it's taking you 10 minutes to pee, or hey, you know, you said you saw some blood in the urine. So those family members are really important. I include them in the conversation because they go on that journey with you. And Brother Evans can probably speak, you know, to that as well.
Yeah. Initially, once we got to the point of diagnosis, yes, it's cancer, then she was attending the doctor with me at that point, especially the first conversation we had with the oncologist. You know, we had, I think we walked in with a list of 30 questions, and so he said, "You guys were by far the most prepared I've seen come in because we just wanted to know what we were going to deal with." And so, and then again, like I said, Dr. Abel, take her with you so she can hear what you miss when they're talking to you. And it's true because you're hearing I have cancer, so that's in your head. Then a couple other things that come by, you heard it, but you really didn't hear it. And so it's good to have a second set of ears that just to hear that. And if it's not out of white, take a good friend, take a good coworker that you are that you have a good relationship with that has your best interest at heart. And so that's the one thing that I certainly say that I'm glad I did do. And so for us, it kind of made us a little bit stronger. So,
what type of support have you needed in terms of getting through the side effects, the symptoms, and the sense of I have cancer?
The biggest thing for me when I found out I had cancer, I felt like I lost my sense of invincibility. Nothing can stop me. And so that lasted a while. That was probably the worst part of it. But just talking to my two cousins that had gone through it, talking with another brother that had gone through it, and just hearing what they had to say, life goes on, you'll be fine. And life does go on, and I am fine. And so it was that little support system right there that helped me over that hump. And so some of the side effects, you know, I would go tell my wife, I said, I'm going to the bathroom every hour. And now this is true. And so right about the time it started, we had to drive to St. Louis for my aunt's funeral. She was 99 in 9 months. We were hoping she got to 100. And so driving to St. Louis, so I was okay sitting still. But the minute I got out that car, it wasn't about putting the gas in the car. It was like straight and find the bathroom. If somebody was in the way, it was going to be a Clorox situation. So that was probably the worst part of it. And that went away probably after about 6 to 8 weeks. And then I returned to normal. Probably the worst thing I have right now is when I go to the gym, depending on what exercise I do, I might have a drip or two. And so what Dr. Moses says, you just don't have to go to the bathroom between every exercise. And that's kind of what I do now, so that's what I do. So that's really not a problem. So I've been able to adapt to the small things that are going on. And so I feel that I don't have any issues, even if I do.
Got it. We've discussed a lot about this disparity. How do we get the word out to people in our community, people in our chapters, people who go to the barbershop with us? How do we tell them about this in a way that they can absorb it?
For me, I think we just have to be real. Like Dr. Brewster told me, it's only one question you have to answer. You want to live or you want to die? The DRE test, yeah, it sucks. No one likes to do it. The doctor doesn't want to do it. You don't want to receive it, but do it and move on. It's just a second. It's not even a minute, and you're done with it. So, but I think the more we talk about it, the more we're open with it. Dr. Moses had me write just a short paragraph for the chapter newsletter, and I received probably 3 calls since then. One, thanking me for being open, and 2, they would share what they were going through. And so I think we have to do more of that to let men know that it's okay. And so hopefully this is the start of something where men will be okay talking about the tests that are uncomfortable. No, they're not fun, but it's necessary. Let's do it, get over it, move on, and get back to life.
Mm-hmm.
I occupy a unique space in life because I'm a physician. My friends, my acquaintances will often come up to me and ask me medical questions. Times when perhaps other people would not have a medical conversation. And this is a particularly sensitive one, but I always appreciate when somebody can take the initiative to ask a question. If it's not the right space for me to answer with the level of detail that I think the question requires, I'll say, look, can we schedule some time? Because I'd like to answer your question, and I'd like to do it a little bit more privately. But I have this unique space. I'm not sure if others really do, but what happens as a result is when I go to my chapter meeting, people will come up to me and say, by the way, did you know that I had prostate cancer? Did you know whatever's going on in their lives? And because of the way our world works, our society works, people don't put on Facebook all the bad things that are going on in their lives.
Mm-hmm.
They always talk about their kid that graduated from an Ivy League school, these kinds of things, but they don't say that I'm dealing with something. Can you help me and support me nearly as often? And so I often find this individual contact shows me a side of individuals that I've known for many, many years that I'm not providing care for, that I just never would have gotten otherwise. But how do we open this conversation in our barbershops, at the gym, at our church, at our family gatherings?
Yeah.
Well,
I think go ahead, Brother Evans.
Well, I'll tell you, at first, I didn't want to talk about it at all. I just want to go in the corner, get better, and move on with life. And so my wife started encouraging me. She said, talk about it more. Just talk about it. So being in that headspace, being in a spot, we had a CIO, he said, we have to learn how to make ourselves vulnerable. And so I took a leap of faith, and all the people that reported to me right before I started treatment, I just went to them one-on-one and told them what was going on. And so if I'm not in the office, this is why I'm not here. And so that made it easier to talk about to anybody. And so I got out of my own way. And so just talking about it made it easier to share with people. And also with one of the employees that I had shared with, her husband was going through. And so now she's reaching out to me on how do I approach him that he feels okay talking to me about it. And so those are the things that we don't realize that we can have an effect on if we get okay with talking about what's going on with us. I'm okay if Dr. Moses can talk about my case all day. I know HIPAA laws prevents him from doing that, but he has my okay to talk about it anytime, anywhere he wants to.
But just your conversation of this is very empowering, and I see in you a great strength. So I think, speaking for all that hear your words, we're very, very grateful that you're willing to take the step to share your story and perhaps even claim some agency over what's going on in your life.
Yeah.
Excellent.
Yeah, I think it's important to just talk about it. The impact of the survivor statement, it's like the guy in church that gives the testimony, right? Like, it's very easy, especially with a prostate cancer diagnosis, to get tunnel vision. And oh man, I'm the only one going through this. Or people who have complications after treatment can feel very isolated. And just talking it out sometimes, it may not fix the problem, but at least there's somebody out there that's been through it or going through it that you can kind of communicate with. But as you said, I mean, there's different organizations that will go out to churches, or I've gone out individually to churches. I've done the barbershop thing. I've done the panels like this. And although we're probably all kind of zoomed out, at least in this forum, you know, we're all in 3 different places, but many people can see this more than if we were just all in one room together. Yeah. There are plenty of reputable organizations, and I say reputable because there's some crazy stuff out there on the internet. You know, it's not hard to find, you know, IHateDrMoses.com or something like that. But, you know, the American Cancer Society, the American Urological Association, where you can get information. But then there's also advocacy groups like the Prostate Health Education Network, which is run by a brother, not an alpha brother, but a Black man, and Zero and Us Too and Prostate Cancer Coalition. So you don't have to go through this alone. You don't have to go through uninformed. And if you are in a position of influence, if you're a chapter president, or if you're part of the Health and Wellness Committee, or if you are a educator or something, you know, incorporate health discussions as part of your agenda and just open it up. And we had a chapter meeting. I think the first time I remember talking in a chapter meeting, probably like 2017 or so. And I had a couple of physicians come in and give a talk about prostate cancer. And once people loosened up, you know, when you ask questions or say, is there any questions? And it was kind of silence. But it just took one brother to say, hey, you know what? I had prostate cancer. And you could kind of see heads whip around. They're like, oh man, brother, I didn't know. You look great. And he gave his story. And then after that, it was a flood of questions. And so sometimes it just takes breaking that ice just to get the conversation started. You'll be surprised, you know, how much you learn and how much you need to know about yourself and the people around you.
That's fabulous. I think that as we've all lived through the pandemic over the last several years, getting credible medical information has become more and more difficult because everyone has the ability and maybe even the right to say whatever they'd like to say, whether it's useful or helpful or hurtful or harmful. Is up for the user to decide. And it's very difficult for someone who hasn't had a urology residency and a prostate cancer fellowship to understand what is useful information. So we're going to put up the websites for the organizations that you mentioned. Can you tell us a little bit about the NCCN? You mentioned that you share their effort.
Yeah, so NCCN means National Comprehensive Cancer Network. And so that is an organization of all the cancer centers that meet a certain standard. And a representative from each one of these centers sits on the various guideline panels. So they make recommendations for breast cancer, colon cancer, lung cancer, et cetera. For prostate cancer, there's actually several NCCN panels. The one in which I'm a member of and chair is the one for early detection of prostate cancer. So that's the one that talks about the screening guidelines, the age recommendations, the PSA levels, things like that. There's another panel that deals with treatment of localized disease, and then another one that deals with more advanced disease. And again, it's one of several panels that make recommendations on how to screen, diagnose, and treat and survivorship of prostate cancer, among other cancers.
Again, that's so important because, as we mentioned several times, early detection leads to better outcomes. Mm-hmm. So this is such an important point. I'd like to bring up another point that's a hot button issue in my family. My mother was born in Tuskegee, Alabama. All those who hear my voice have a sense of what the Tuskegee syphilis experiment might or may not have been. And that affects how many individuals in our community interface with the healthcare community, and even more with the healthcare research community. Brother Moses, you are associate professor in urology. Can you speak to what it means for a person to participate in a research study, and particularly a person of color to participate in a research study?
Yeah, that's such an important topic. And, Tuskegee is at the forefront, but either intuitively or directly, we know about medical experimentation that has happened on Black individuals and vulnerable individuals in this country. And so there is a righteous, I would say, not necessarily avoidance, but a righteous skepticism about clinical trials. And so that's one of the things, and I talk to companies all the time. I say one of the first things you need to do is acknowledge that their skepticism is real. It is based on facts. And the more people try to dismiss it, the more people are going to hang on to that. In light of that, I tell my Black patients, I tell all my patients, but certainly my Black patients, clinical trials are governed by a set of standards that have to be followed. There are the Belmont principles. There are institutional review boards. There are data safety monitoring committees. And so if you're going to participate in a trial, you want to ensure that all of that information is available. And any trial that has met muster, so to speak, would be on clinicaltrials.gov, clinicaltrials.gov. And you cannot get on there without, again, institutional review board, without data safety monitoring, without acknowledgement of all participants. Prostate cancer in particular, clinical trials are very important because, again, of the statistics we talked about in Black men, but Black men are severely underrepresented in prostate cancer trials. And that's a little crazy to me because, number one, we suffer greater from prostate cancer, so we should be overrepresented. But number two, of the trials that have been done, many of them have shown that Black men have as good or sometimes even better outcomes compared to white men. And so some of the treatments like immunotherapy and some of the advanced hormone therapies, they've shown better survival among the Black population compared to others. And so when I talk about clinical trials, when I'm talking to organizations, to the companies, I say, hey, look, you need to have someone that looks like who you're going after, right? So if you bring in a bunch of old white guys and talking about this number and this data and this, some people are going to tune out. So you need to diversify. You need to have African Americans on your clinical trial design team, because some of the concerns that may be in the community, you might not even recognize unless you're a part of it because you haven't heard or you haven't felt it. And so that's what I tell the companies. And then I tell my patients, any clinical trial that I would recommend to you, I have vetted, and I'll give them the information for them to go look at it. And then I'll tell them too, is it a trial that is treatment versus placebo? Because there's always been concern about Black men or Blacks being shunted towards the placebo. So you want to make sure that it truly is randomized, meaning, a coin flip. Or I'll tell them it's whatever the standard treatment is now versus the newer treatment. And then I'll talk about, how's the newer treatment different? What are we looking for? But in any circumstance, you will be getting the standard treatment. And for most cancer trials now, there's very few that are placebo, at least in the stage 3 or phase 3 trials. Most cancer trials now are whatever the standard is currently, and then it's the standard plus the experimental or newer therapy. And that is to ensure that everybody is getting at least the gold standard, and then potentially, whatever is newer. But I would say clinical trials are very important. Participate in them. I run clinical trials. I offer clinical trials. And I've talked to organizations to make sure that equitable treatment is a part of the protocol.
Outstanding. Brother Evans, could you share some of your final thoughts as we begin to wrap up the evening?
I was sitting here thinking as we were talking, and just really, I sort of want to continue to do my part to help break down the barriers of discussion and getting okay to talk with it. And I have to give my sister some credit to that too, because when the diagnosis first happened, I told my brother and my sister at the same time. And so she asked me to talk to her kids, and one which is a male in his early 20s. And so I sat them all down and we had a discussion. And they were such a wonderful part of my going through the process and recovery, just knowing that they were in my corner. They still call me, "Are you okay? How you doing? How your numbers look?" And so just building that little support around you has really made this an easy journey. But for us, I just think we just have to start. If we get one, that's a start. And if we get one, we're going to get three. We get three, we're going to get 9. So talking about it, church, frat meeting, over coffee, having that friend that is really your mirror, and a mirror can't lie. So you have to have those people in your life too. But it's not as scary as we think it is. It's not taking away your masculinity like some think it is. It's just a test. That's all it is. And we get over it and we move on.
Brother Moses, could you share one more time your guideline recommendations on who gets checked and when?
Yep. So it's always shared decision making. It's always discussing with your physician. For men with normal life expectancy, more than 10 years, get that baseline PSA and rectal exam at 40. And as Brother Evans said, you can start at 35, particularly if you know there are a lot of other men in your family with prostate cancer or men who were diagnosed at young ages. But get that baseline number. Get it again at 45 if it's normal or a reasonable number, and then start at least once a year or every other year, starting at age 50. Most of the guidelines will take you up to age 70 or 75. And again, you look at your overall health. So a very healthy man who's out exercising and in good physical condition, if they're 75, you can get screened because, you may live another 20 years. For unhealthy men, we de-escalate because the treatments for prostate cancer can have a lot of side effects. But in that 40 to 70 range, that's where you want to be tracking it, keeping up with those numbers. And again, based on your age, there are some acceptable ranges. But as Brother Evans said, even if you're kind of in the acceptable range, but there's some kind of a jump, then that needs to be investigated because there's been a change. But those are the general screening guidelines.
Those are fabulous points of information. Are there any others that you'd like to share with us as we close the show?
Yeah, I'll echo what Brother Evans said. Get tested. Don't kind of get over that fear. A lot of fear is based on the unknown. And so the way to get over that is make it known. Get the information, get that knowledge, and move on it. Because at this point now, there's no reason to become a statistic from prostate cancer. Yep. You should be, if anything, even if you're diagnosed, you should be a survivor. Okay. And so get out there, get that information, get tested, and save your life.
That's just fabulous. Knowledge is power, and we appreciate it. I appreciate the time that both of you have given today to help us better understand what's going on. Brother Evans, your testimonial has power, and it makes you powerful. I'm greatly appreciative. Again, I've known Dr. Moses since he was just Kelvin, walking around the medical school for the first time. But what he's done is truly remarkable and exceeded even the lofty expectations that I had for him then. And so I appreciate the time that he spent tonight, the effort he's spending in the community in general. We couldn't bring this education to you without the efforts and the vision of Brother General President Lonzer, who helped support the Surgeon General initiative, and our own Surgeon General, Brother Jeffrey Sterling, who has created this platform from vaporware. We couldn't do this without them, but we especially couldn't do without those that are in the audience who are listening. If you've liked what you've heard, we do this kind of conversation essentially every other week. We moved this particular conversation to tonight to take advantage of Prostate Cancer Month, which is in October. Our usual and regularly scheduled presentation is going to be actually next Thursday evening at 6 p.m. right here on Facebook Live on the Alpha Phi Alpha channel. But also, if you or someone in your community wishes to gather more information, this particular broadcast is recorded, and all of our broadcasts are recorded on the YouTube Sphinx TV channel. Again, my name is Dr. Victor Narcisse, Spring 90 initiative of Tulane University Rho Iota chapter. I'm now with Alpha Eta Lambda chapter in Houston, Texas, and I'm grateful to each and every one of you. Thank you so much. Have a wonderful evening. Be safe.
Good night.
Be safe.